All right, let's get right into it. Today, we're diving into a clinical guide for major depressive disorder. Think of this as a practical roadmap built on the latest evidence-based guidelines to help us understand, diagnose, and really truly manage depression effectively. So here's how we're going to break it down. First, we'll nail down the core definitions. Then, we'll walk through diagnosis and assessment. After that, we'll get a bird's-eye view of the main therapeutic choices, do a deep dive into medications, and then wrap it all up with some key clinical tips you can use in your practice. Okay, first things first, we need to define our terms. What exactly is major depressive disorder, or MDD? Getting this right is the foundation for everything else we're going to talk about.
At its very heart, MDD is defined by one of two things: either a persistent low mood or a major loss of interest or pleasure in things you used to enjoy. You'll hear clinicians call that second one anhedonia. This is really the core experience we're focusing on.
Now, the official diagnostic criteria are very specific. You don't just need to feel down. To diagnose a major depressive episode, a person has to have 5 or more specific symptoms, all happening within the same 2-week window. And here's the crucial part. At least one of those symptoms has to be either that depressed mood or the loss of interest we just talked about. So what are these symptoms? Well, there are 9 of them, straight from the DSM-5. And as you can see, they cover a whole spectrum of human experience. You've got physical changes like sleep going haywire or big shifts in appetite. You've got cognitive issues like trouble concentrating. And of course, you have those deeply painful emotional states like feeling completely worthless. But remember, for a diagnosis, these can't just be fleeting feelings. They have to cause real, significant distress or mess up a person's ability to function day to day. Okay, so we know what MDD looks like. Now for the next logical step. How do we actually identify and assess it in a real-world clinical setting? Let's get into the practical workup. And this leads to a super practical question, right? In a busy primary care office, you don't have an hour. How can you screen for depression quickly, but also reliably? Well, the guidelines give us a fantastic tool for exactly this. These 2 simple questions are from the Patient Health Questionnaire 9, the PHQ-9. And they're brilliant because they directly target the 2 core symptoms of MDD. Answering these can be a powerful, efficient first step in figuring out if something more is going on. Of course, a screening is just the start. A full assessment is absolutely crucial. We have to be detectives here. Could these symptoms be caused by a medication or substance use? And this is so important. We have to ask about any history of mania or hypomania. Why? Because that would point us toward bipolar disorder, which is treated completely differently. And without question, every single assessment has to include an evaluation for suicidality. That's a non-negotiable for safety. Look, the diagnosis isn't the finish line. It's the starting block. To really manage depression well, we have to use what's called measurement-based care. So at the very beginning, that means a full workup: history, physical stats, and some key labs, like checking thyroid function, since a thyroid issue can sometimes look a lot like depression. After that, it's an ongoing process. We constantly track symptoms, side effects, weight, and suicidal thoughts. It's dynamic. Right, with a diagnosis in hand, let's talk about treatment. You know, the modern approach to depression is not a one-size-fits-all thing. It's all about a multifaceted strategy, combining different tools to build the best possible plan for each person. The evidence really points to 4 main pillars of treatment. First, you've got pharmacotherapy, medication. Second is depression-specific psychotherapy, things like cognitive behavioral therapy, or CBT, and interpersonal therapy, or IPT. Third, and this is becoming more and more important, we have tech-based options, like guided web-based therapy, which really helps with access. And finally, for more severe or treatment-resistant depression, there are neurostimulation therapies. The best results? They often come from mixing and matching these in a collaborative way. Okay, now we're going to zoom in and really focus on pharmacotherapy. For so many people, medication is a cornerstone of treatment, and thankfully, we have clear, step-by-step clinical guidelines to help us make good decisions. And this is it, the treatment algorithm from the CANMAT guidelines. Now, I know at first glance, it can look a little intimidating, but trust me, this is an incredibly valuable roadmap. It gives us an evidence-based path for how to start, how to adjust, and what to do next with medications. So let's walk through the key steps. See, it's all about logical progression. You start with a first-line medication. Then, and this is so important, you check for any early signs of improvement at the 2 to 4 week mark. If things are moving in the right direction, great, you continue. If not, your first move isn't to just switch drugs. Nope. First, you double-check if they're actually taking it, and then you see if you can optimize the dose. If that doesn't work, then you think about switching or adding something else. And once someone gets to remission, you don't stop. Maintenance for at least 6 to 12 months is key to preventing a relapse.
Let's talk about two of the trickiest side effects, the ones that often make people want to quit their medication: weight gain and sexual dysfunction. The guidelines give us some really practical advice. You can, of course, counsel on lifestyle changes, but you can also consider switching to a different medication, like bupropion, that's less likely to cause these problems. And for sexual side effects in men, adding a PDE5 inhibitor can sometimes be a helpful option.
We also have to think about special populations, and postpartum depression is a big one. Here, psychotherapy is actually the preferred first-line treatment, but if medication is necessary for someone who is breastfeeding, options like sertraline are usually the go-to because of their safety record. And some meds, like doxapen, are pretty much off the table because of the potential risk to the infant. Okay, let's pull all of this together. In our last section, we're going to distill everything down into some high-yield clinical pearls, the kind of stuff you can take and apply right away. Here's some fantastic practical advice. Don't try to be an expert on every single antidepressant out there. Instead, pick a couple from different classes and really master them, know them inside and out, and always try to tailor your choice to the patient's main symptoms. And this is interesting. Right now, the evidence just doesn't support routine drug-level monitoring or genetic testing for most people. So what do you do when the treatment just isn't working? Here's a simple, clear plan. Step 1, go back and make sure the diagnosis is right. Are we sure this is MDD? Step 2, check the basics. Are they taking the medicine? Is any substance use getting in the way? And step 3, the guidelines suggest that after 3 good tries with different treatments that fail, it's time to refer for a psychiatric consultation.
And finally, a hugely important point about stopping treatment. You can't just stop antidepressants cold turkey. It's so important to taper them down slowly, usually over 4 to 6 weeks. This helps avoid a nasty discontinuation syndrome. And you have to be extra careful with drugs that have a shorter half-life, especially paroxetine and venlafaxine.
And that really brings us to the final and maybe the most important question of all. Our job isn't just about getting someone to remission. The real goal, the bigger challenge, is helping our patients stay well for the long haul. It's about preventing relapse and maintaining that hard-won wellness. This really drives home that depression can be a long-term condition, and that continuous collaborative care is everything. Thanks so much for joining me for this explainer.